Okay, let's unpack this. I want you to imagine a room. It's quiet, very serious. You've got this long table. And on one side, you have surgeons. On the other, radiologists, pathologists. I mean, these are the heavy hitters of a hospital.
Right.
And they're all just staring at these images on a wall, passing around reports. And they're trying to solve a puzzle that, well, on paper, just doesn't add up.
You're describing a tumor board. It's pretty much the Supreme Court of medical decision-making, especially for these really complex cases.
Exactly. And today, we are, in effect, sitting in on one of these sessions. We've got a whole stack of documents here, clinical notes, imaging reports, pathology slides, and they all concern one patient.
A 49-year-old man, a seller from Orangetown.
In his case is, I think, a perfect example of a medical standoff.
It is. The central conflict here is between what the doctors see with their own eyes, the clinical reality, and what the laboratory tests are telling them.
Right. Because here's the setup. This man has a massive lesion on his face. It looks like cancer. It's behaving like cancer. It's literally eating into his cheek and his lip.
But,
and this is where it gets so complicated, he has had not one, not two, but 3 biopsies. And all of them basically say nothing to see here, just some inflammation.
which puts the medical team in a really, really dangerous position. I mean, do you treat the piece of paper that says benign, or do you treat the massive ulcerating growth that is consuming the patient's face?
And that's the dilemma. So on this deep dive, we're going to walk you through this patient's timeline. We'll look at the seemingly innocent event that started it all, the high-tech imaging that finally revealed the truth, and, well, the incredibly complex engineering required to rebuild a human face.
Let's start with the patient himself, because usually when we talk about aggressive head and neck tumors, especially squamous cell carcinoma, we expect a certain profile. You know, often a history of heavy chain smoking or chewing beetle nut.
Good guy, yeah. But the sources note he's a 49-year-old male, average build. He is a known hypertensive, so high blood pressure. But otherwise, his medical history is surprisingly clean. No major red flags in his background.
But the origin story of this tumor is incredibly specific. It wasn't some slow, mysterious growth.
No, he knows exactly when it started. 1.5 years ago.
With a cheek bite.
A cheek bite. I mean, I've done that. Everyone listening has done that. You're eating too fast, you bite the inside of your cheek, it hurts like crazy. It swells up for a day or two and then it heals.
Precisely. And that's a crucial lesson in pathology right there. A normal traumatic ulcer heals. The oral mucosa, the lining of your mouth, is one of the fastest healing tissues in the human body.
Wow.
The rule of thumb is, if a wound in the mouth hasn't healed in 2 weeks, that is a massive red flag.
2 weeks versus 1.5 years.
Yeah.
So this gentleman has had a non-healing ulcer on his left buccal mucosa, the inner cheek, for 18 months.
And ignoring that timeline is just, it's dangerous.
It didn't just stay a sore, though. It grew. The history says it progressively extended to cover the right angle of his mouth. But here's the thing I found most surprising in the notes.
What's that?
He says it was painless.
That is often the most deceptive part of oral cancer. We naturally associate, bad disease with pain. But early stage tumors can hijack the body's nerves or just grow around them without triggering those pain receptors, at least initially. The report says for over a year, no pain, no bleeding.
Only the last 5 months did he have minor self-limiting bleeding, just a few drops here and there, and functionally, he's fine. The notes say no trismus.
Meaning he can open his mouth fully.
Right. And no dysphagia.
He can swallow. His voice hasn't changed.
Which just speaks to the body's incredible ability to adapt. He must have adjusted his chewing, his speaking, just compensating for this mass.
He did. But once you actually look at the patient, the clinical exam tells a horror story.
Let's try to visualize this because the description in the file is really vivid. The doctors describe the lesion as ulcerofungating.
That's a very specific term. It means the lesion is doing 2 opposing things at once. It's digging in like a crater. That's the ulcer.
Okay, ulcer part.
Exactly. And it's also growing outward, kind of like a cauliflower or a mushroom. That's the fundating part.
And it's big. The dimensions involve the left 1/3 of both the upper and lower lips, and it extends deep into his cheek. We're talking about a surface area of roughly 4 by 5 centimeters.
To give you a sense of scale, that's like, imagine a golf ball or a large lime just sitting right on the corner of your mouth, destroying the lip structure.
And it's not just on the surface. The notes on palpation. They describe it as firm, tender, and friable.
Friable is a key word in oncology. It means the tissue is so fragile and vascular, so full of abnormal blood vessels that it just crumbles or bleeds if you barely touch it.
Wow.
But the most alarming word in that physical exam is fixed.
Fixed to the underlying structures.
Right. Normal skin, normal lining. It slides over the muscle. If you touch your cheek right now, you can wiggle the skin. Fixed implies this lesion has anchored itself down. It's sent roots into the muscle or bone underneath. It's not just on the face, it is part of the face now.
So any medical student, anyone, looks at this massive, fixed, crumbly, ulcerating mass and thinks, carcinoma. Cancer.
No question.
So they send him for biopsy.
Correct. Standard procedure.
And this is where we hit what you call the biopsy paradox.
Huh.
He goes to the trauma center on July 31st. They take a sample, they send it to Akali Way. The result comes back. Squamoproliferative lesion.
Okay, let's define that because it sounds technical, but it's actually pretty vague. Squamo just refers to squamous cells, the flat cells that line your mouth. Proliferative just means they're multiplying fast.
So it's just saying busy cells.
It's effectively saying these cells are very busy, but it does not say these cells are invading. It's not a cancer diagnosis.
So the doctors probably think, okay, maybe we missed the spot. He goes back on August 17th, another biopsy, this time sent to Chatai Lab. And the result,
Squamoproliferative lesion.
the same thing.
Consistent but confusing. It's confirming this rapid growth, but it's denying cancer.
So they try a third time. Civil Hospital, November 28th, it's months later. Sent to AQ again. Result.
Squamoproliferative lesion. No convincing evidence of invasion.
This has to be a nightmare scenario for a diagnostic team. You've got 3 reports from reputable labs telling you it's benign, but the patient's face is literally being consumed by a tumor. How does a pathologist miss a tumor the size of a golf ball 3 times? I mean, is the cancer invisible?
No, it's likely sampling error. Think of the tumor like a jelly donut.
Okay.
If you take a bite from the very center, you might just get jelly, or in this case, necrosis, dead tissue, inflammation, crust, bacteria. The actual cancer cells, the active agents, they're usually at the edge.
At the dough.
At the dough, exactly, where they're actively invading healthy tissue.
So if the surgeon just snips the nasty-looking center, they completely miss the crime scene.
That's the theory. The report explicitly notes surface bacterial colonization and focal fungus spores. It's a dirty wound. The cancer is likely hiding deeper at what they call the advancing edge of the tumor. That's why the tumor board documents recommend a deep incisional biopsy from the advancing edge. They need to go deeper to prove what they already suspect is there.
Because despite the paperwork saying benign, the provisional diagnosis listed in these documents is still carcinoma of the lower lip. They're not buying the benign story.
They can't afford to. If they treat it as benign and send him home with antibiotics, he dies. It's that simple.
And when they finally put him through the imaging machines, the benign theory just completely falls apart.
Right, this is where the technology surpasses that initial biopsy. They ran a CT scan of the neck with contrast.
And the CT gives them this 3D map of destruction. It confirms a heterogeneously enhancing soft tissue mass. What does heterogeneously enhancing mean in plain English?
It means it looks messy on the scan. Homogeneous would be smooth, uniform. Heterogeneous means some parts are bright, some are dark. And this usually indicates a mix of active, bloodthirsty tumor cells and areas of dead necrotic tissue.
I see.
But the CT answers the most critical question: what is it eating?
The notes mention the buccinator and the orbicularis oris.
Yes, these are vital facial muscles. The buccinator is your main cheek muscle. It's what you use to blow out a candle or keep food between your teeth when you're chewing.
And the orbicularis oris.
That's the muscle ring that circles your mouth that lets you pucker your lips, seal your lips.
And the scan confirms the tumor has invaded these muscles.
It does, which explains why the lesion felt fixed on the physical exam. It has literally woven itself into the meat of the face.
Is there any good news in this scan?
There is, and it's significant. It has not eroded the mandible, the jawbone. Bone invasion is a total game changer. It makes the surgery much, much more radical. You often have to remove part of the jaw. The CT also shows it hasn't crossed the midline of the face. It's strictly on the left side.
Okay, so local invasion is confirmed. Then they did a PT scan. Now this looks for metabolic activity, right?
Yes, cancer cells are hungry. They consume glucose at a much higher rate than normal cells because they are dividing so fast. The PT scan uses a radioactive sugar tracer to find those hotspots, and the report says the lesion is FDG avid.
It lit up.
Like a beacon. That confirms the high metabolic activity, which strongly supports malignancy. But the PT scan found something else, didn't it? Something that biopsies definitely missed.
The lymph nodes. The scan picked up suspicious activity in the neck nodes. Levels Aya, Ib, Aya, and Ayava.
This changes the staging entirely.
Help us map that out. When we say levels, where are we on the neck?
Think of the neck as a series of train stations for your lymphatic system, which drains fluid from the face. Like level I is the first stop right under the chin and the jawline. Level 2 is the next stop, the upper neck, right along that big jugular vein. The fact that nodes in these areas are lighting up suggests the cancer has bought a ticket and is leaving the station. It's traveling.
So huge size, muscle invasion, lymph node involvement. The document mentions stage IVA.
That's the likely staging. In the TNM system, that's tumor node metastasis, this is likely T4A. T4A means the tumor is massive, over 4 centimeters, and invading deep structures. And the N is what creates the stage 5B diagnosis.
It's the nodes.
It's the nodes. It means the cancer is no longer local, it's regional.
So the next steps checklist in the notes is basically them preparing for war. Step 1 is that the biopsy we mentioned to get the legal proof.
Right.
Step 2 is an MRI of the face. Why an MRI if they already have a CT?
MRI is just superior for soft tissue resolution. The CT is great for bone, but the MRI can actually see the nerves. They need to know if the cancer is traveling along the nerve sheaths, something called perineural invasion.
And that changes the surgery.
It changes how widely they have to cut.
And step 3, dental clearance. That seems almost trivial compared to stage 5 cancer.
It sounds mundane, but it is absolutely vital. The notes mention poor orodental hygiene. If you are about to reconstruct a mouth, you cannot have rotten teeth full of bacteria sitting right next to your fresh sutures. It's just a recipe for a disastrous infection.
An infection that could rot the new face they're about to build.
Exactly.
Okay, so let's talk about the solution. The surgical management section of the plan. This isn't just cutting out a sore. They call it a wide local excision.
It's a geometry problem. To cure cancer, you need clear margins. The plan calls for an R0 resection with a 1 centimeter margin. That means they have to cut out the visible tumor plus 1 centimeter of healthy-looking tissue all the way around it in every direction.
But if the tumor is on his lip and cheek, taking a centimeter margin means they are removing a huge part of his face.
They are. They will be removing about a third of his upper and lower lips and a significant chunk of his cheek. It leaves a massive defect.
And that's just a tumor. They also have to deal with the neck nodes. The plan lists a modified radical neck dissection, type 3.
This is a very specific, very technical operation. In the old days, a radical dissection just took everything: muscle, vein, nerve. It left the patient with a stiff neck and a dropped shoulder because that main nerve was cut.
And the modified version.
A modified type 3 is much more elegant. They remove the lymph fat pad containing all the nodes from levels through V-clearing all those train stations, but they meticulously preserve 3 vital structures.
Which are?
The spinal accessory nerve, so he can move his shoulder, the internal jugular vein for blood flow, and the sternocleidomastoid muscle for neck rotation.
So they clean the house, but leave the supporting beams.
That's a great way to put it. But now at the end of this resection phase, you have a patient with a cured neck, but a massive hole in his face where his lips and cheek used to be.
This is the reconstruction phase. How on earth do you replace a third of a lip and a cheek?
So the tumor board laid 2 main strategies. The first is a local option. It's called a Karapanzik flap.
Karapanzik. That sounds like a magician's move.
It kind of functions like one. Imagine the mouth as a clock face. If you remove the tissue between, say, 2 and 4 o'clock, you can cut the remaining lip tissue, rotate it like a dial, and stretch it to close that gap.
Wow.
The brilliance is that it keeps the nerves and blood vessels attached. The new lip can still feel and move.
But is there enough loose skin on a face to just stretch it over a 5 centimeter hole?
And that's the concern here. Given the size of this defect, remember, 4 by 5 centimeters, a local flap likely isn't enough. It would leave him with a tiny, tight mouth, what we call microstomia. He wouldn't be able to put a spoon in his mouth.
Right, which is why the notes also list distant flaps, specifically the RFFF and the ALT.
Yes, these are the big guns of reconstructive surgery. RFFF is radial forearm free flap. They essentially harvest a patch of skin, fat, and blood vessels from the inside of his forearm.
And the ALT.
Anterolateral thigh, taking tissue from the thigh.
So they take a piece of his arm and just sew it into his face.
It's way more than just sewing skin patches. This is microsurgery. They have to detach the blood vessels from the arm, bring that whole flap of tissue up to the face, and then using a microscope, stitch those tiny arm arteries, we are talking about vessels 1 to 2 millimeters wide, to the neck arteries.
Plumbing, they have to reconnect the plumbing.
Exactly. And if that plumbing fails, if a clot forms in that tiny connection, the tissue dies. It turns black within hours. It's incredibly high stakes. But if it works, he has a new cheek.
Will it look like a cheek? or feel like one.
It will provide bulk and lining so he can keep food in his mouth and speak clearly, but it won't have muscle to pucker like a real lip. It's a patch, a biological seal.
So he wakes up with a scar on his arm, a scar on his neck, and a new cheek. Is he done? Is that it?
Not necessarily. The adjuvant therapy section outlines the post-game plan. Once that tumor is out, the pathologist analyzes it under the microscope. This is the real diagnosis. And if they find high-risk features,
Like what?
like if the cancer was touching the nerves, or if it had burst out of the lymph nodes, then surgery isn't enough.
Then comes the chemo.
Chemotherapy, specifically cisplatin, and likely radiotherapy as well. The goal is to mop up any microscopic cells that the surgeon couldn't see that might have been left behind.
The document also mentions a concept called field cancerization. That sounds ominous.
It is. Think of it as the soil theory. The idea is that the entire field, the whole lining of the mouth, has been exposed to the same genetic triggers or carcinogens over the years. So even if they cut this specific weed out perfectly, the surrounding soil is still primed to grow new weeds.
So it's not just about this one tumor, it's about the whole environment of his mouth.
Exactly. Which is why the final point in the management principles is long-term surveillance. He is a high-risk patient for the rest of his life.
So let's just zoom out for a second. We started with a guy who bit his cheek. He waited a year and a half, largely because it didn't hurt. And now he's facing a 10-hour surgery, microsurgery, potential radiation, and a completely reconstructed face.
It's a sobering reminder of why clinical judgment matters so much. If the doctors had just looked at those 3 biopsy reports and said, great, the lab says it's benign, here's some cream, this man would likely be terminal within a year. The tumor would have eroded his jaw or spread to his lungs.
It really highlights the mission, as you put it, of the tumor board. It's a safety net, it's checks and balances.
Absolutely. The biopsy paradox here was solved because the team looked at the patient, not just the paper. They trusted their clinical experience over those initial data points.
And what really stands out to me is just the resilience of the human body.
That's the most haunting part of this for me. This man has a T4 tumor invading his facial muscles, yet he can speak and swallow. The body just compensates. It hides the dysfunction until the structural damage is absolutely catastrophic.
It's almost like the body is gaslighting you into thinking you're okay.
In a way, yes, it protects you from the dysfunction until it absolutely can't anymore.
Well, that makes you think twice about ignoring those little signals our bodies send us.
Indeed. If something doesn't heal, get it checked. And if it still doesn't heal, get it checked again.
And maybe get a 4th biopsy if you have to. That's it for this deep dive into the mystery of the non-healing ulcer. A huge thank you to the medical team whose notes allowed us to piece this story together. Stay curious, stay healthy, and we'll catch you on the next one.